GI anatomy, retroperitoneal structures, along with important GI ligaments, and the digestive tract anatomy with histology. All right, so first and foremost for the anatomy, I'm just going to kind of run through this stuff. We're going to break up these videos separately because I think that there's a lot to learn in GI anatomy, and it will make it so much clearer for you as you kind of do all the pathology. So first and foremost, what they want you to know is the retroperitoneal structures, okay? And the retroperitoneum is essentially just a separate space that separates. And once again, this is important to know. There's nothing like really separating the retroperitoneum from the peritoneum, okay? I want that to be clear. A lot of the times, people I don't know, there could be a lot of students that believe there's like a sheath or there's some type of tissue that separates the retroperitoneum from the peritoneum. No, that's not the case. If you do an abdominal surgery and you go in, you just can push the GI tract out of the way and you will see the retroperitoneal cavity. Okay, there's nothing blocking it. And I'm sure you guys have seen that in your anatomy course from M1 here, but I just want to make it clear. Now, so this is just the posterior portion, right? It's the posterior portion it's kind of like near your back, right? Of the peritoneal cavity. But the reason it's important is because any injury to this area of the structures that are in that area could lead to a retroperitoneal bleed or gas formation, anything like that. But once again, don't get too bogged down on that idea of retroperitoneum compared to peritoneum, all right? So they just like to ask the structures. What is in the retroperitoneal space? Here we go. First one, the suprarenal adrenal glands, okay? The adrenal glands, obviously, are going to be in it with the kidneys. So the kidneys and the adrenal glands are together, obviously, and they're going to be in the retroperitoneal space. All right? Along with that, you're going to have the aorta and the IVC. The aorta and the IVC, I mean, just think about this for 1 second. Your body, once again, is a very, very smart machine, okay? Very smart in the way that it's made. So why would the body want to put the aorta and the IVC, two of the largest amount of blood flowing through your body, okay? Why would they put it out front where someone could just like hit you and there's no protection from the rib cage, there's no protection anywhere, right? So it makes sense that it would be placed in the retroperitoneum. Same with the kidneys, right? You want to protect those kidneys. The GI tract is like, kind of fluffy. It can be like pushed around. It doesn't really get affected too bad by like any trauma or, minor hits. So that's why it's kind of up front protecting those important structures which are in the back in the retroperitoneal space, okay? So there you go. You have the kidneys with the suprarenal glands, the aorta, and the IVC. Now, a couple other things. The duodenum, okay? The first part is not a part of the retroperitoneal cavity, but everything after is. So the duodenum, the second part all the way to the end, is going to be in the retroperitoneal space. That's just something that they like to quiz you on. The pancreas, except for the tail, is in the retroperitoneal space. That's another stupid thing that they like to quiz you on. Just keep that in the back of your mind. These are just memorization stuff. The ureters are also in it. So you have the kidneys, the suprarenal or adrenal glands, and then the ureters. The colon, they love to test on the colon, which parts are retroperitoneal versus not. The colon, descending and ascending, are retroperitoneal. The transverse portion is not, okay? And then the esophagus, all right, the thoracic portion of the esophagus, so such a little portion, that's pretty much low, that's really low yield. And then the rectum is partially, okay? And the way that they remember this is SAD, pucker. S for suprarenal glands, A for aorta and IVC, D is for the duodenum, second through fourth portions, P is for pancreas, except for the tail, remember that. Ureters is U, C is colon, which is descending and ascending. They want you to know that specifically, descending and ascending. K is for kidneys, E is for esophagus, and R is for rectum, okay? So remember, keep that in mind. I remember specific questions on the descending and ascending colon and the rectum, as well as the pancreas, except for the tail. So keep that in the back of your mind. All right, moving forward to the important GI ligaments. So all ligaments is that they're just going to connect the main structures of your GI tract together, okay? And they're named perfectly. There's only one ligament that's like named odd. It's called the falciform ligament. And the falciform ligament connects essentially your liver to your abdominal wall, okay? So that's all you really need to know about the falciform ligament. And they could potentially ask about the derivative of it. It's derivative of the ventral mesentery, okay? But it just connects the abdominal wall to the liver. Now, the rest, you have hepatoduodenal ligament, hepatogastric ligament, okay? So let's start with those two. Hepatoduodenal ligament, where do you think that would connect? What two structures do you think that would connect? Hepatoduodenal ligament. It's named perfectly. It connects the liver and the duodenum, okay? Now, what you need to know about this is that the hepatoduodenal ligament contains the portal triad, okay? And the portal triad is the proper hepatic artery, the portal vein, and the common bile duct, okay? So The hepatoduodenal ligament contains the portal triad, which itself contains the portal triad is the proper hepatic artery, the portal vein, and the common bile duct. Very important pathology association here, because what happens here is that, let's say there's some type of bleeding, intra-abdominal bleeding, okay? Surgeons have come up with the maneuver known as the Pringle maneuver. And what they'll do is they'll clamp the hepatoduodenal ligament, which means they're clamping the portal triad. If the bleeding stopped, they know that the bleeding is associated with the portal triad. If the bleeding doesn't stop, they know it's not associated with the portal triad, okay? So that is the Pringle maneuver, all right? It's helpful in finding intra-abdominal bleeds and ruling out whether it's coming from the portal triad or not. So they just clamp the hepatoduodenal ligament by doing so, okay? Next is hepatogastric ligament, low yield. By the way, the only high yield one really is the hepatoduodenal, but I'm just going through this for completeness. Hepatogastric, it's going to connect the liver to the stomach, hepatogastric. And then you have the gastrocolic, the gastrosplenic, all right, and the splenorenal. Gastrocolic is going to connect, obviously, the stomach to the transverse colon. The gastrosplenic is going to connect the stomach to the spleen, right? So these are all very easy, very straightforward. There isn't much to it. Just remember the hepatoduodenal ligament contains that portal triad. Know what the portal triad is: the proper hepatic artery, the portal vein, and the common bile duct. And then the Pringle maneuver is clamping the hepatoduodenal ligament so that we can see where the bleeding is coming from. All right, next is going to be the digestive tract anatomy, okay? I remember learning about this in M1 year. Once again, it's not too high yield, not too important, but I'm just going to run through it. The layers of the gut wall. You have the mucosa from inside to out, from the lumen out. So you have the lumen, then you have the mucosa. You have the submucosa, okay? And the submucosa contains the Meissner's plexus, okay? Submucosal nerve plexus, also known as Meissner's, all right? And that helps secrete fluids. Okay, that's the first thing that you need to know. Then you have the muscularis externa, which contains the myenteric nerve plexus, or the Auerbach plexus, okay? You have to know both those names, and that's for motility, all right? And it makes sense because obviously the nerve plexus near the muscularis externa, or the muscular layer, is gonna need help with motility. It's gonna give some innervation for those muscles so motility can occur. Makes sense, right? And then the last thing is serosa or adventitia, not really too high yield. But what they want you here to know for pathology reasons is that ulcers extend into the submucosa, okay, or in the inner or outer mucosal layer. Erosions are only mucosal, okay? So the mucosa is only affected in erosions, whereas ulcers can get much deeper into like the actual muscularis area, okay? Now, for the digestive tract histology, what they want you to know is to be able to separate out where you're at by just looking at a photo, okay? And this is important, okay? So first off, esophagus. You have non-keratinized stratified squamous epithelium. Okay, the upper 1/3 is stratified or striated muscle, controllable, whereas the middle and lower 2/3 is smooth muscle. That's very key. Okay, at the stomach you have gastric glands. It's the only location you're pretty much going to see them with parietal cells. The parietal cells are those pink cells, pink cells. The chief cells are going to be those purple cells within the stomach. The duodenum has villi and microvilli so that there's a lot of space for absorption. You also have the Brunner's glands. If you see Brunner's glands, you know that you're in the duodenum. And what the Brunner's glands do is that they secrete bicarb because it's connected right to the stomach, right? So at that pylorus, where you're going from the stomach to the duodenum, you're going to be kind of secreting some of that stomach acid into the GI tract, into the duodenum. So we have to have some of those Brunner's glands to produce bicarb and balance out that acidity, okay? You also will have crypts of Lieberkahn, not that important, contains stem cells. And then for jejunum, you have villi and crypts of Lieberkahn. The ileum, the way that you're able to tell about it is the Peyer's patches, which it could become like they're just lymphoid aggregates, right? And in the colon, you're going to see no villi at all, okay? Once again, I ran through that quickly, probably for a reason, right? I mean, it's not too high yield, but it's important for you to know what I kind of just discussed. In the next chapter for Anatomy on GI, we're going to discuss the blood supply and how kind of everything works in the associated pathologies with the blood supply and vessels.